Yeah. Let me off YouTube first. So loud.
Okay.
Come present the thing.
Okay.
Uh,
So the patient is Kais.
Yeah.
He's a 7-month, 26-year-old boy born
Mm.
prem at 23 weeks and 6 days. Corrected gestational age is 3 months and 3 weeks. Birth weight was 508 grams and current weight is about 5.3 kg. He had a history of admission to NICU for about 5 months from February to May. So February to July. This patient has, because he's prem, he has underlying resolved RDS with right-sided pneumothorax. So X-ray done at birth showed right-sided pneumothorax. However, 1 day later, the X-ray done showed that it was resolved. He was also given 2 doses of DEXA at birth, a bit prior to birth, and also surfactant given at 1 hour and 6 hours of life. He also has resolved grade 1 intraventricular hemorrhage. Ultrasound cranium done at 31 weeks of life showed that it was resolved. He also has anemia of prematurity, currently on folic acid and multiple supplement. As well as he also has patent ductus arteriosus. The last echo was done in July. The PDA was 1.8 mm and the PFO was about 1.6 with no dilation of the heart chambers. He also has a bilateral hydrocele and under pre-surgical follow-up, as well as also retinopathy of prematurity. He's under Optel follow-up. The last TCA in I think it was last month. Noted that it is responding to the intravitreal injections. He also had laser done for both eyes. Lastly, he has a moderate bronchopulmonary dysplasia. So there was a difficulty intubating at birth and also extubating. And then he initially was on CPAP, PEEP7. However, over time managed to wean down to room air in July. So since then, it's just been on room air. So currently now he's presenting with fever for the past 4 days. The fever, its highest documented temperature is 39 degrees at home. Mother gave syrup paracetamol regular every 6 hours, and the fever was on and off after that. It will resolve after giving the paracetamol. He also had a runny nose for 2 days with a clear discharge, as well as reduced feeding for the past 2 days. The feeding normally he has about 4 ounces every 2 to 3 hours, and then reduced to about 2 to 3 ounces every 4 hours. And lastly, he also has reduced urine output for the past 2 days, according to the mother. For his otherwise, he has no nausea, vomiting, no cough, no rash, no ear discharge, or any red eyes. For his birth history, like mentioned earlier, he's born prem at 23 weeks via SVD. Then for development wise, following the corrected gestational age, he is up to his age. For gross motor, he has no more head lag. He's able to, when prone, lift his head up to about 90 degrees. And then for fine motor, he has palmar grasp and hand regard. Speech wise, he's still cooing, as well as able to follow sounds up to about 90 degrees, turning his head. And lastly, for social, he's mouthing, he's lifts his hand up to be carried, and he's happy being interacted with by other people. Diet, he's on Dugro formula milk, 3 to 4 ounces every 2 to 3 hourly. For his family history, his parents are both 36 years old in the army and have no known medical illness. He has a sister who is older sister who is 3 years old, also born prem at 24 weeks and completed 5 doses of Synergis. They stay in an apartment in Bukit Jalil, and he's taken care of by a babysitter during the weekdays. Immunization wise for him, he is got about 4 doses of Synergis and planning to complete 5, and his next vaccine will be MMR booster. Okay, and then on admission, on examination, the child was alert, pink, well.
So at this point, before examination, what's your differential
So at this
for the fever?
point, for my differential, I think my provisional would be UTI.
Okay. Why?
Because of the non-specific symptoms, as well as reduced urine output and reduced feeding.
Okay.
Uh,
Okay.
and then differential would be Kawasaki disease. I think that was one we were looking out for as well, because of fever, but then no rash and no other conjunctivitis in that.
Okay. So examination.
On examination, child was well. I think at the time sleeping, pink. Anterior fontanelle was normotensive. Peripheries were warm, good pulse volume, and not in any respiratory distress or not in no recessions.
Patient looks well. Toxic.
Does not look septic.
Okay.
Yeah, and didn't have any edema on the face, rashes, or conjunctivitis. Lungs were clear.
OS under general. OS under general punya examination. The growth, height, weight.
The growth height weight actually all below third centile,
Okay.
which expected in this kind of child.
Alright.
Yeah. Lungs were clear. Heart, there was no murmur, and upper abdomen was soft, not distended.
Okay, so since you said your provisional diagnosis is UTI, so what specific finding you want to find in patient with UTI? Any specific things, examination finding that put patient at risk to have a UTI?
Can look at the genitals.
Okay,
genitals.
so what about
If there's
genitals?
Any phimosis.
Yes, one. Okay. Some more?
Also the hygiene.
Can, yes.
Any foul smelling urine when you open the pampers.
Yeah, okay. Smell girls or boys? This patient?
This patient is a boy.
Okay,
Yeah.
if girl?
If girl, you look for any vaginal discharge.
Yes.
Yeah.
Okay, alright. Plus redness around the areas, plus maybe some labial addition or something. Okay, just pointing some structural thingy lah, the obvious one. That's genitalia. What else? Down there, at the back.
Around the anus as well, I think. Any.
Just a bit above than anus, apa lagi?
Oh.
At the back. Nak tengok apa your back?
The back.
What do you examine newborn screening at the back for the baby?
Any tuft of hair?
Yes.
Yeah.
Okay. So what does it indicate? The hair tuft. What else? Well, other than tuft of hair, some more? Apa lagi? What do you examine at the back? Looking for what? Sacral dimple. Alright. All these pointers to possibly spinal dysraphism, some spinal bifida occulta or whatnot. Okay.
Okay.
Alright. So, neurology, don't need to examine for UTI.
It was not examined for this patient.
Okay. So if you want to examine, what you want to look for?
I think I examined the lower limb neurology.
Yes. Why?
In case of spinal bifida.
So what can
be on examination, they have the frog-like
Yeah.
appearance of the legs,
Okay.
and then also hypotonia.
So you will look for signs of neurological deficits lah.
Yeah.
Depends, can be lower tone, it can be upper motor neuron lah, depend on the lesions. Then of course this one pointing to what?
Neuropathic bladder.
Neurogenic bladder.
Neurogenic bladder.
Not neuropathic bladder. Okay. Alright. So this patient in the end we treat as what?
So in the end, this we took the investigations. So first was the UFAM. The first UFAM was clean catch. Sorry, the first UFAM was a back sample. So it was leukocyte 3, pH was normal, nitrite was negative. So we decided to take another sample via clean catch along with the culture. The clean catch sample also showed leukocyte 3 with nitrite negative. Cultures were pending at that time. Bloods, RP was normal. FBC, HB was also normal, 11.3, white cell was about 21, and the CRP is 113. So following the investigation results, we decided to treat as UTI because the leukocyte was high.
CRP also high, right?
CRP high, yeah.
Alright.
And it's white cell.
Okay. So why we decide to take the clean cache instead of just base your treatment on the back sample?
Because the back sample is not a very sterile way of getting the urine, can be contaminated.
Yes. Okay.
the surrounding skin.
So does clean cash is the gold standard?
No, gold standard is suprapubic aspirate.
Okay.
Yeah. But
Does it practice widely?
No.
Not really, right? Have you seen it then before?
Here no, only
No.
in and out. Here no, but only seen the in and out catheter lah.
Yeah.
Yeah.
Okay lah. Some center probably still practice suprapubic lah. I know for a fact Serdang practice suprapubic for prolonged jaundice.
As the first.
As a way
Oh,
to collect your urine sample. Okay. Alright. So one more thing about examination, you must look at the BP, blood pressure.
Okay.
Why?
I think if UTI with
So this could have been a long-standing UTI, probably missed before, so probably may have some CKDs already. Still possible, yes. Patient can present at early stage, can later stage, can present as complication. So we don't know what kind of patient we're gonna get. Okay. So ultimately, what kind of antibiotic we start?
actually we started on IV augmentin for this patient.
What augmentin? What does it cover?
Augmentin will cover gram negative.
Yeah. Okay.
Is the main
What part of or which part component of augmentin yang cover the gram neg? Augmentin is what? Combination is what?
Amoxicillin clavulanic acid.
I see. So amoxicillin is just a normal penicillin, right?
Yeah.
Okay. So
the clavulanic acid.
yeah, the clavulanic component lah. Usually there is have wider coverage of gram negative lah. So most common cause of bacterial cause of UTI is what?
It would be E. coli.
E. coli. Okay. What else?
Others Klebsiella,
Okay.
Proteus, can have Pseudomonas also,
Yeah.
and GBS lah.
Yeah. It depends on the age lah most of the time. Okay. So babies, E. coli is quite common. Klebsiella is quite common. Okay. It just whether that E. coli or Klebsiella, whether that one is ESBL or not.
Okay.
Okay. So that's why it's very important to to get the cultures. Alright. So ultimately, this patient end up culture what?
So ultimately, this patient they cultured E. coli, scanty growth. I think called less than 5 lah colony.
Okay.
So we actually finished 4 days of augmentin, and then after the results came out, it was resistant to augmentin lah,
Yeah.
and sensitive to cefuroxime, so we changed to syrup cefuroxime prior to discharge.
Alright. So how do you interpret their results? So it depends also lah. It depends the clean cash sample whether they send on time or not. Sometimes you send late also, they might get contamination that might can grow something else instead of what but in the end, because it's clean cash, patient also clinically better, so fever resolved on its own. We didn't repeat this RP. So ultimately we changed to cefuroxime now oral, then I just give longer duration lah. But so because it's E. coli, it's not really SBL per se, but there is some resistance already. So do you want to get ultrasound or not? This kind of patient.
So for this patient, because he's under 6 months and presenting with first time UTI, we get the ultrasound in 6 weeks.
Okay. So is this patient, is baby a girl patient? E. coli, sensitive bugs. Want to get ultrasound?
So same age, right?
Yeah.
I think still would get in 6
alright.
weeks. Yeah.
The young one usually we get lah. The bigger one, you probably can wait and see. Alright. However, if what kind of bugs memang triggered you to basically get the ultrasound straight away? Is patient already like 3 years old, 4 years old, big one. But if the bugs doesn't grow E. coli, so what kind of bug usually you probably wanted to get the ultrasound?
Probably the non-E. coli lah, the Klebsiella and Proteus.
Okay lah, if we non-E. coli one, so we probably need to get the ultrasound. Sometimes there might be some mild structural abnormalities that can predispose patient to UTI, but not severe enough to cause that patient to have UTI early in the age. Okay, so ultimately ultrasound, what you want to look for?
So ultrasound, you want to look for any structural abnormalities, any dilation of the kidneys or along the ureter.
Okay. So if there is some structural abnormalities, what is the next step?
So okay, so if there is any structural abnormalities, usually 4 to 6 months after the acute phase of illness, you go for the DMSA scan lah. Yeah.
Okay. So what you want to look for in the MSA scan?
So that one you look for scarring, renal scarring.
Okay. MCUG?
MCUG, you will see the whole flow of the urine, so you can see if there's any structural abnormalities causing any reversal of the flow.
Reflux lah?
Reflux, yeah.
Okay. So this kind of patient, if got reflux, got renal scarring, recurrent UTI, what usually we start them on?
You can start them on prophylaxis.
Okay, so prophylaxis lah.
Yeah, trimethoprim.
So before you start trimethoprim or Bactrim, what you need to watch out for? We ask for what? Something at birth one.
Something what?
Something we take at birth. Antibiotic Bactrim got sulfite, right?
Or you take the G6PD.
Yeah, this is PD lah. Okay, some patients start Bactrim, some patient maybe just trimethoprim alone lah. Okay. So, the features of UTI varies according to the age. So in unit, what do they present usually?
In unit, usually quite non-specific. Can be fever, reduced feeding,
Okay.
hypotension, vomiting, reduced activity level.
Okay. If unit, what else?
Sepsis.
Okay.
Sepsis.
Some more? Unit usually they what compared to infant?
Increased frequency of urine.
No. Unit usually they want data of life. Diorang apa? Selalunya jaundice or not?
Jaundice.
Yeah, in unit they present also with prolonged jaundice. So don't forget that lah. But of course they present with failure to thrive as well. Okay. Infant same as unit lah, but without the jaundice lah usually. Up to until what age they basically have some typical urinary symptoms?
I think age of 3.
Yeah, by more than 2 years old, probably they start can complain of abdominal pain or something. But the rest, fever, house mailing, dysuria, probably they might be able to tell, might not be able to tell lah. But once they go to preschool or school going age, they probably have same symptom as adult already. So what does fever indicate? Does it indicate lower urinary tract infection or does it indicate higher urinary tract infection?
Both you can have.
Yes, both can have lah. So, but if got very high fever like that, so sometimes you might want to think about high upper urinary tract lah usually. Because sometimes lower urinary tract typically they don't have fever per se. Most of the time they don't have the fever. Okay, but when you have fever, especially the young one, you suspect the high urinary tract compared to me. Okay. Alright. Okay lah, soalan yang I prepare you tahulah. I sudah prepare